All right, guys. So kind of already went through this PowerPoint slide a little bit. We're going to start from the beginning. And this is chapter 3. You guys should already know about the normal growth and development across the lifespan for women. But we're going to kind of hit some highlights. You can look at the models, you know, about the Erikson stages, Kohlberg level of moral development. Feminist theories of development, you can read those. Stages of the adolescent, we consider the early being ages 11 to 14, mid being ages 15 to 17, and of course your late 18 to 21. So we talk about biological changes, and that starts kind of out in puberty. The next slide kind of talks about breast development, menarche, and how girls always reach puberty before boys do. Mm-hmm. So they actually get that growth spurt first and kind of start evening out, and then the boys come up afterwards. And I know that Terry has something she wants to say about menarche, especially with us being in primary care, you know, more likely working as family nurse practitioners, you need to know that you'll be seeing, you know, these young women come in and they just started their periods. So she has some pearls of wisdom.
Just know that their periods can be normally irregular for that first, at least the first year. It's not uncommon, even sometimes into the second year of their periods. Just try to reassure the parents that this can be normal and we're not going to worry about it. And then, you know, their breast development. I have a story about a young patient. She was 12, 13. Her breasts had developed. She had started her period, but her breasts were different sizes, and she wore different, you know, or even to a cup or two size difference. And I've had patients tell me that doctors told them that it would catch up with each other, and I was like, that's not true. That's not going to happen. But I had a mom that brought her daughter in, and she just had a hard time understanding what was happening. And, you know, I just said, you know, unfortunately, this was not going to change. The breast wasn't going to catch up with the other size. But there was nothing wrong with her. And how I ended up helping her to understand that there was nothing wrong, but to help the patient herself. I sent her to a store that caters to women who's had breast cancer and mastectomy, and we had her fitted for an insert. So that way she could even wear a bathing suit top and not feel self-conscious about that.
How wonderful.
So but I want you to know that does happen from time to time, and there's nothing terribly wrong with that. It's too bad for the patient, but you know, oftentimes you read that they can, once they're in their older age, in their early 20s, they may have a breast implant so that they can make their breast the same size. So
yeah, I think that's important. So just so you guys know, I'm going to give you like some other things that I kind of want you to be aware of. Know about even precocious puberty could start before the age of 8. Mm-hmm. And I say that because I think you guys need to know that it could potentially start earlier. I know a lot of female patients are coming in, and it seems to be like getting younger and younger. Delayed puberty also is if you have no breast development, and that's by the age of 12. Knowing your Tanner stages, I would tell you, especially for certification exam purposes, is so important. And we do that with your hands, honestly. And Tanner stage 3 is the one that you start getting breast and areola. The penis thickens and darker coarse hair starts to curl. That's like the biggest stage where you start seeing that development, Tanner stage 3. So you have to be able to know what that looks like in these patients, and know your Tanner stages and that kind of thing. So I wanted to add that in there. So there's menarche. We talked about that. There's your Tanner stages, just talked about that. Neurodevelopment, it says it occurs earlier in girls, which makes sense because puberty starts earlier in girls, so that kind of makes sense. The psychosocial and cognitive development, they start developing a sense of identity and autonomy. I know if I haven't heard it more than once, my 18-year-old is like, well, Mom, I'm an adult now. Okay, sure. Sure you are. And everybody knows that peers are so important in this age group, 100% over. Can't stress a lot of this enough. Identity development among those LGBTQ population groups. And we've kind of already touched base on that already, a separate lecture. So clinical application, it says female adolescent morbidity includes their pregnancies, sexually transmitted infections if they've ran away, or suicide. Trust always is needed with this group. When you can get a trusting working relationship with these patients, you're going to get a lot more out of them, and you can care for them more appropriately, in my opinion.
And they're going to be able to explain to you what's on their mind and what's affecting them.
Yes. So then we go into early adulthood, and this is more late adolescent to perimenopausal, so from 18 to ages 35 to even 50. And it is referred to as the reproductive years. So biology, optimal time for reproduction in this patient population group usually have regular ovulatory menstrual cycles. Would you agree with that?
Absolutely. And sometimes I have to remind women 40 and older, they can still get pregnant. For some reason, they think they can't. That's very important.
I'm one of those. I mean, I was 38, but I'm one of those that said, oh my gosh, this really can happen. So, and then of course we have to always touch base on unhealthy behaviors that may be potential risk factors for them or that population group. And don't ever forget cardiac disease is the biggest killer of women. And you know, the symptoms are atypical. And so you have to understand that as well. Psychosocially, this early adulthood patient population groups, they have two crises during early adulthood, and that's development of intimacy versus isolation, entering life partnerships. Caring for others, involving parenting. At this point, they may be parents, they may be caring for others, caring for elderly, even their parents, and that kind of thing. So in the clinical environment, so to speak, we may be having conversations as providers to these patient population groups regarding contraceptive decisions, substance abuse. Are they having any intimate partner violence, which it's coming up in a couple more lectures. Do they have stress and any psychiatric illnesses?
Yeah, I see that every day. You know, even when you're trying to make a decision about what to counsel a person if she smokes or if she, vapes or smokes pot, you don't know. Yeah. And so you just got to look at the whole aspect. That's 100%. What I love about nurse practitioners. We look at the whole aspect of a person.
Yeah, the holistic approach for sure. Yeah. In the midlife, we're talking about perimenopausal years up to menopause. And this is more of regards to like a transition time. So that's always good. Biology, we're going through perimenopause and menopause, marking that transition from young adult to now what we consider midlife. So what do these patients look like? They have decrease in their estrogen levels, which induces hot flashes. The genitalia could be decreasing in size, breast structure starting to change, and changes are decreasing in skin elasticity.
A lot of women have no clue that their genitalia begins to change, and they one day have noticed it looks different, and it's like
wow,
just it's part of that, those changes that we end up going through if we live long enough.
Oh, exactly. Exactly. So psychosocially, there's factors that have a greater effect on that midlife. You've always heard of midlife crisis in women. They start buying that new car, getting a dog, or or whatever the case may be, or they experience increased feelings of physical and emotional well-being and greater control over their lives.
I think this generation, though, talks a lot more than the former generation about it. So they're more accepting of these changes that are about to occur. Sometimes they fear it, but then, sometimes they're more open to talking about and embracing it, actually. So,
yeah, see, that's awesome. Clinical. So what are we going to be seeing this patient population group for? They may be less interested in sex. So we got to be ready for those kind of conversations. What about ageism and bias caused by age are also common in Western society. Then we get to the older women. These are the patients who have completed menopause. And I know Terry's kind of sit on that a little bit, saying what about the age of 58, we're thinking that women should be going through or completed.
Early 50s is when average woman in the United States begins to, she stopped her period, or that's the median age. So that kind of gives us a guide to understand and help that patient know, okay, you're approaching this age, you're going to see some changes. And then menopause, that means you've stopped your period. So that just kind of gives us an age range of when we should be looking for menopause.
Right. And so don't forget that these patients may have a limited or a fixed income. So that is very important to them as well. And don't forget to have conversations surrounding exercise, weight, nutrition.
Yeah, because I'm all the time just encouraging women to make some changes to become healthier, because if they can keep their body healthy, they're going to live longer, or they're going to experience less diseases.
Exactly.
Comorbidities,
100%. Yeah. Making better changes in their life, Psychosocial development, they're often caregivers for their ailing male spouse or partner. There's some studies with the LGBTQ population group, and those that involve gender-related distinctions need to be explored more. And we've talked about that. We'd like to see more studies surrounding some of these groups. So in the clinical aspect, what are we going to be seeing this population group for? It says it can be substantial. Women, of course, we know have a longer life expectancy than men. They are usually okay with their ageism and sexism. The resilience, positive view of life, despite their aging. I don't know. My mom is not one of those people, so they're not all textbook that way, because she has a difficult time with that. Feminist theories can promote health and wellness in older women. So you can look back at those and see how those may relate. So you look at Appendix 3A, Danows Model of Development, and that's a framework of relational tasks and obstacles throughout the lifespan. So y'all can read about that as well. Both men and women to better understand and assess and develop goals for therapy. So that leads us into a menopause. And let me share that screen. Here we go.
I love the artwork that they've chosen to put with menopause, because it is.
I picked that. Are you not proud of me for some of
that was
these
in the
things?
book or what? But
No.
it is multifactorial.
It is.
And it can affect a lot of parts of our
Yes,
lives.
I kind of went through some of this stuff, and I was like, I'm gonna see what I can do that maybe relates a little bit. So kind of did good. You're proud of me. I'm glad. So statistics, 2 million women reach menopause each year, and that's a lot.
It is a lot, and we're living longer, and we're exploring this thing called menopause, and more women live 1/3 of their lives in menopause. So like your mom, you were talking about how women, they're trying to prevent aging. They're trying to, and that there's nothing wrong with that. But the other part of that is we can not fear it, but embrace it, so that we got. And I think it helps us to understand that we're not going to always be wrinkle free. We're not always going to have that full head of hair that we've always had. A lot of women complain of thinning hair over time. But embrace the age that we are, and let's do what we can to keep what we have.
Speaking of the woman who went and worked out before she came in today, okay, just so you know.
Upper body today.
See, look at that upper body. Really, what's workout? Okay, whatever. So age 52, average age, you just, we kind of
51, 52.
Yep, kind of said some of this stuff. So midlife changes, issues, we kind of hit a little bit of this. The children are starting to leave the home. They may have had one or both of their parents pass away. And even career changes. What does that look like? Have they retired? Are they at home?
Or lost a job because of their age.
True.
And I see so many women who, we call this age the sandwich age, the sandwich generation, because they may be dealing with their adult children or problems with grandchildren. They may be trying to enjoy that empty nest, or they're grieving the empty nest. Or they may be also dealing with aging parents or even aging spouses, but and they plus they may be working. So it's the pressures of all of that they're dealing with. And the first person that they're not going to deal with is themselves, the health of themselves. I may see a person and I hadn't seen her in 5 years. It's like, where have you been? And she says, well, I've taken care of everybody else and not myself. So, I encourage her to, let's get back on track and what we need to do to make sure that you stay healthy. So I have that conversation a lot. Yeah.
So important.
I think it's interesting watching I'm looking at that.
Yeah.
How things have changed. How that it's kind of gone back and forth, up and down with menopause and the exploring of hormone therapy. And back in the 60s they found a fountain of youth, and then 15 years later they found that, oh my gosh, this causes cancer, and what can we do to prevent it? But then they find in the 80s, like, oh my gosh, it does, there is some health benefits to replacing the hormones after menopause. So that's
you've seen all of this, really, haven't you?
Absolutely.
Like, oh yeah, we used to do this. Oh no, we're not going to do it. Oh no, we are going to do it.
You stay in this career long enough, and you're going to look back and you're going to see these changes, what we used to do and what we no longer do. And one of the big ones is the WHI study. That's the next one.
There it is.
That was life-changing to gynecology world, because it was such a huge study, such an important study, and so much come out of that. One of the things that, hormone replacement therapy prevents osteoporosis, and, it was touted as they even come out with, oh, there's this new hormone replacement that will prevent osteoporosis. And it's true. I remember that, it was a patch. And
yes, I remember that. My mom had it, not me.
All that you have to do is use this patch, and it's just enough that it's going to protect your bones. And then everything hit. And so like, well, no, you don't want to take hormone for that anymore.
So funny.
It leaves this society wondering, what do we do? What do we do? So, my advice to you is do the best you can with the information that you have. Yeah. And, research-based information that you have at the time,
I think you have to continue to look at that, because it is changing, and there's evidence here that it does.
Exactly.
So you have to keep your education on the forefront. So natural menopause, this is cessation of menstruation, and we're talking for at least 12 months in a row.
So I help to celebrate with my patients. Have you hit that 1 year mark yet? Yes. It's like, okay, you're in menopause now. And they go, whoop, whoop, you know, so, and sometimes like, yes, it's like people want to get rid of their period.
Right. Exactly. Exactly. So there is a perimenopausal period, and that's 2 to 8 years prior to the last menstrual period. Early postmenopausal period, first 5 years following menopause.
Yeah. So a lot of things can happen in this. It's important to realize these changes, right? These stages of menopause.
Absolutely. Yeah. Absolutely. So here we go. In perimenopause, we should expect hormone levels to fluctuate.
I love that wildly.
Yeah.
That's the truth.
Ain't that true?
I love that wildly
from day to day.
Yeah, and that's what I have to encourage. You know, women. I have to teach them. Yes, you will have these fluctuations. They come in. I think something's wrong with my hormones. Can you check my hormone levels? It's not going to be very helpful because we know that your hormones can fluctuate from day to day to month. So you've got hormones going on. It's not going to be helpful to check the levels today. They just need that reassurance that this is expected. Let's help you through this time.
Right, exactly. So women produce estrogen and androgens after menopause, but the ovaries are no longer producing any functional follicles.
But that production is very low, very low. So it's important that they realize that's.
What's the earliest that you've seen? And it says occurs between ages of 40 and 58. What's the earliest?
So I saw, and this is bizarre. She was 28.
What?
Yeah.
Really?
But that's very rare. Very rare.
Or,
I don't recall.
Oh no, I was just wondering.
Recall.
No, it's fine.
But
I was like, whoa.
You know, I expect menopause no earlier than 40. So know that it's rare, and I'm surprised I even come across that person. But and that was, you know, other than surgical menopause, you will still find women who have had hysterectomy with oophorectomy and because of endometriosis.
Right.
They really, really, really try to avoid that at all costs because it's very hard for a woman at that age to tolerate not having hormones.
Oh, I cannot imagine.
Yeah, but I start looking for it expecting at age 40. So somebody before that, and I recently had a 38-year-old said something's wrong with my hormones, and I think I'm going through menopause, and you know, it's like, no, you're not. Not yet. You might be approaching peri, because if you think about perimenopause being, you know, a short period of time for a few years, if she's one that's going to go through menopause in her early 40s, she very well may be experiencing that fluctuation.
Absolutely. So look at genetic factors such as smoking, how big are they, health status, socioeconomic status. That also can play a factor. So I wonder about that 28-year-old.
Well, and just like you were asking, did her mother go through it? You can't always go by her previous, you know, her family or older sister or mother. Sometimes it's, you know, sometimes you'll see women kind of doing the same thing in the family, but you can't always count on that.
No.
That's not a prediction.
Right. Other causes, and you just, I swear, Terry, honest to God, she has said that, or even from like an ablation by medication, chemo, or radiation.
Yeah, we see this where some women, you know, they've been diagnosed with cancer of some sort, and the chemo maybe put them in menopause, or the radiation therapy. Right. But sometimes, and it's only temporary, and that's the lower thing. Temporary menopause occurs when the normal ovarian function is lost, but then it resumes. And that's an incidence of they may have been going through cancer treatment of some sort and forced into menopause, or that was the result of it.
Right. So it says premature menopause occurs before age of 40, definitely that 28-year-old for sure. So how do we diagnose it? So absence of menses for 12 months. And it says no more getting FSHs.
Yeah. Well,
do you still do it?
I still do.
I know. I had my preceptor did. I ain't judging. Hey, listen.
I still do.
I did.
It's a test that we know that can fluctuate based on that pituitary ovarian axis. It still fluctuates. You can't say 100%, but it's not an inaccurate test. You just have to realize that it fluctuates. But yeah, that's what the book says.
I know. My preceptor did the same thing, so I'm not one to say. I mean,
and the anti-Mullerian hormone, I know that we are able to do that, but that's what I was telling Michelle. I'm not sure how cost effective that is to know how many the number of follicles that one has. I know they do it in reproductive endocrinology whenever they're looking at the age of a woman. She's at their facility wanting to know, is she still too old to have children? And they will do that test, but that's, I don't know how expensive that is. Maybe I need to use that more of it.
Right. So the vaginal dryness and hot flashes.
Well, the perimenopause includes many of the menopause symptoms. So they go, I think I'm in menopause. Well, how are your periods? Well, I have a period every month, but I'm having hot flashes, night sweats, vaginal dryness. And it's like, well, you're not in menopause. This stage is called perimenopause, and you will oftentimes feel these symptoms, and you gotta have sympathy for them, right? Because some women it's very severe, and then you got to be willing to help them through those symptoms.
100%.
Yeah.
So what are our differentials? It says diabetes have similar symptoms, medication, alcohol, even particular medications. So make sure you assess their symptoms.
Yeah, I have a list of medications that cause hot flashes.
There you go.
Because
I think it's important.
Well, I had a man that brought his little mother from the nursing home to come see me. She was 85 and was having hot flashes. And he just knew I could help her with her menopause symptoms.
Oh my God.
Yeah, I know. It was pitiful. It was like, oh my God, you broke my heart. But it's like, this is not menopause.
Well, it's hard.
Yeah, we got to look at her medications, something else going on here, that this is not menopause. So
precious. I don't even know what to say. So presentation variation of what they kind of say is menopause, what they're experiencing. It's unique and personal. We can say that, right? It's related to reduced levels of estrogen and progesterone, and even their body size. Type and severity can vary between patients. There's your hot flushes, and sweats. Can have issues with their sleeping, urogenital changes. We've kind of talked about how's their sexual function and their libido, maybe.
And let me say this about sleep disruption. You would think that would be night sweats, that they're waking up being,
right, but
that may not necessarily. They may not be having those vasomotor symptoms. It may just be they cannot stay asleep. Yeah, it's a miserable thing when they're affected like that.
So what are hot flashes? I think we all kind of understand. So it says it's intense heat sensation, but may not be followed by sweating. So, you can kind of see what that means.
I had a lady one time, she was older, and I said, boy, I'm hot. I said, I must be having hot flashes. She said, darling, when you have a hot flash, you will know it. And so, and I tell you, she was right, because when I did experience a true hot flash, that it was this overwhelming heat sensation that come from deep within. It was nauseating. It only lasted just for a moment, but I thought, okay, that's a hot flash there.
Wow.
But yeah, she
So
said,
you can differentiate.
she set me straight. So it's different than, oh,
That's
it's a little warm in here. To, yeah, this overwhelming and truly, when a woman has this, she knows exactly what you're talking about.
Oh my God. Oh my God. I'm not looking forward to this period of my life. Can we stop the lecture now?
Some women don't experience this, but
they can vary. I'm going to keep that in mind. It can vary. So hot flushes. It says it's like a hot flash, but it's flushing over the face and upper chest. Is this kind of like a reddening kind of color?
And it's embarrassing to the person because she's the only one in the room that's flushed like that. And she may be in a meeting full of men or young women, and all of a sudden it overcomes her and she's tearing off her clothes and she's fanning herself.
I've seen people like this.
And it's just like, oh my gosh, and it's terribly embarrassing to them.
Hot flushes.
Mm-hmm.
Cultural consideration. Of course, we need to take those into consideration. So that those symptoms could also vary with their cultural considerations.
Mm-hmm.
Midlife health issue. Are we overweight? Are we obese? We need to make sure we have those conversations with patients because that can be a struggle at this age. It's not as easy to lose weight at this age, right?
And it is a very, most of the time they're bringing that up, though, I have to say.
Good.
Yeah. And it's not, but if you have to be the one to bring that up, it's not fun. But you have to come up with your own way of attacking that issue.
Difficult conversation. Yeah. Cardiovascular disease, their risk actually increases after menopause. So make sure you're looking at cholesterol levels on these patients, assessing the risk factors, and having those critical conversations that surround that.
So let me say something about this because that's in the information that we read about.
Yes.
Hormone replacement. So there's a difference between your own natural hormones, that is that natural protection against cardiovascular disease. And once your body does go through menopause, our women's risk of heart disease goes up close to a man. I think y'all probably know that, but it's not understood if taking hormone replacement or even natural hormone replacement, is that the same benefit as our own natural hormones gave us protection? We don't know that part.
Wow. Yeah. Wow. So we have to think about diabetes. The likelihood of developing type 2 diabetes increases with age as well. And then all the other stuff, of course, go in with risk factors to that. Cancer, leading cause of death from cancer in United States women are lung and bronchus at 23%. Then we get breast at 15, colon and rectum at 8, pancreatic at 8. This also increases with age. We've talked about osteoporosis and what that looks like in these women. So,
well, it used to be the standards of care was that as soon as a woman was menopause, within about a year, you would start a bone density test to start screening for osteoporosis. And for a lot of women, we start losing our bone as natural menopause occurs. But it's accelerated that first 5 years, that early postmenopause, that first 5 years after menopause, we lose bone, and then it begins to kind of taper off. The newer recommendations now, I think that's North American Menopausal Society. I saw NAMS earlier in this. Their recommendation now is to not start screening at that point in time for the average woman. Of course, with women with higher risk who may have history of cancer treatment, who are heavy smokers, thyroid issues, then you may want to get a DEXA scan earlier. But the woman now, we're only looking, usually the average lady at 65 is we're beginning to do our bone density screening test. And that's part of GYN, that's part of what I do. And I don't know if that's just our particular practice, because we have our own DEXA machine and it's been there as long as I've been there. But we do look look for and screen women for osteoporosis. So a lot of times women will ask, well, when do I start doing that? It's like, well, most women is at age 65, because what they were finding when we were starting screening postmenopausal women too early is that we were over treating and over scanning. So, you know, it's normal bone loss, and then it kind of starts to stabilize. And then we start by 65, then it starts to drop again.
Right. Right. There we are, thyroid disease. Mm-hmm. Screen men and women every 5 years after the age of 35. Then depression, risk increases during that midlife era caused by those hormonal fluctuations.
Absolutely, see it all the time.
Yeah.
Well, and a lot of other factors.
Right there.
Yeah, other factors, you know, your children growing up, they're going off.
Oh, and you're very sick about them.
Yeah, or problems with their adult children. Yep. And, you know, I find some women, it's real sad if they lose a job and they've just gone through menopause, and they don't feel like that they almost feel worthless in the workforce because they're too old. And it's like, that's not so.
Right. Exactly. Exactly.
But
so sad.
A lot of things that affect them.
So sad. Dietary changes. We really need to talk to patients honestly about symptom management and how we can educate them, avoiding or reducing foods that seem to trigger those hot flashes. Make them drink water, as you just got your water bottle. Now she exercises and she gets her water bottle.
Let me tell you about the triggers.
Let's hear them.
This is a typical conversation. I'll tell women, because women come, well, what can I do about these hot flashes? Well, let's talk about food triggers. Caffeine is a big one. Whether it's coffee in the morning and they're waking up at night, it's still caffeine in their system that can trigger those hot flashes. Hot liquids. So in the morning, whenever they're drinking their coffee and they can't keep their makeup on because they're sweating it off, that's one of those triggers. Foods high in sugar, a big trigger. So women who typically eat sugar throughout the day, they don't realize, they think they're burning up with hot flashes, but in essence, they have found that women who reduce or cut out or eliminate most of particularly the simple sugars in their diet, they can control their hot flashes much better.
Look at that.
Yeah. Alcohol is a big trigger. So if any of us, and my kids always know when I've had a glass of wine because my cheeks turn red, and then anyway, so alcohol. But you think about alcohol triggering that, it goes quickly into the bloodstream as sugar. So so caffeine, hot liquids, foods high in sugar, alcohol, and then spicy foods.
I can see that.
Yeah. So they'll start thinking, well, I can't tolerate spicy foods, and I don't drink any caffeine. So I get to the sugar one and I go, oh yeah, there we go.
That's funny. That is so funny.
That's one way. That's one thing without medication that you can offer a patient who may be experiencing hot flashes. One thing she can do that she can control to see if that helps reduce hers.
That's awesome.
And exercise.
Exercise. There we go. So vitamins and supplements, limited data on effectiveness, but I know you've mentioned some things.
Yeah, there is. And some women nowadays, they're not afraid to try supplements, and you know, they're not FDA approved or regulated, but if somebody wants studies to back these up, they vary. But if it's something that they can try on their own without having to go toward hormones, they're willing to try it. Yeah. So there's several brands that are packaged with, but Black Cohosh is one of the herbal supplements. There's one that's packaged with both Black Cohosh and soy in it. And some women do find some good results with that, and it's certainly safe to take. Except women who've had breast cancer treatment, I would not recommend that for them because there can be some phytoestrogens in that and still get that. But for phytoestrogens to cause cancer, there's no data that supports that. There's several things out, red clover, and then there's a lot of the homeopathic that I'm not aware of.
Right.
But yeah, and then even acupuncture, as we talked about before, there's, you know, some women will find that that's helpful for them during this time.
So vaginal lubricants and moisturizer to relieve vaginal dryness. We've kind of talked about that a little bit with the elderly patient population group. Clothing and environment, wear layered clothing. You just talked about the woman that had the hot flashes that started ripping off her clothes. Yeah, hopefully she had layers underneath those clothes when she was ripping them off. So they kind of know how to dress and kind of having those conversations. What's breathable, what's moisture wicking fabric in case they are kind of sweating, so to speak.
They don't wear scarves anymore. They, you know, the turtlenecs, they just don't wear that anymore.
It's gone. What about the room temperatures, turning down your heat?
Yeah, and keeping the room cool. That's very helpful. Though I oftentimes have patients say, "Oh, I just freeze my husband to death," and I'm like, "Well, he could put on clothes. You can't take any more off."
That's right. That's exactly right. Smoking cessation, always.
Big one.
Always.
Big one. And there is actually a basis behind this that they have found that nicotine kind of takes away the estrogen in the body. That's why we have more bone loss for those women who smoke, but also hot flashes. And I've read studies where they have found that longtime smokers may go through menopause early, naturally.
Which makes sense.
Yes, it does. So
no, estrogen. Hello. Stress management increases with menopause. I think we've talked about that. It's individualized depending on what their family situation is. Sleep, and there's that sleep disruption, and maybe you need to talk to them about what that looks like. What does that mean? Why are you not getting sleep?
And when they say I'm not getting any sleep, and it's like, well, do you have problems falling asleep, staying asleep, or both? And many times, no, I don't have any problems falling asleep. It's I wake up and I can't get my mind to stop. So, you know, approaching sleep hygiene, considering melatonin, or so there's other things that they can do, but as a provider, you need to be able to give them something healthy to help them sleep, even if it's medication that you're prescribing. Everybody's trying to stay away from the hypnotics these days, but exploring other medications that may be safe to take to help them to sleep.
Right, I agree with that. Mental function, make sure you know that, of course, memory loss, cognitive functions also decline with age. So mind stimulation, I know a lot of people say like Sudoku or crossword puzzles, things to keep your mind sharp. I've also heard that walking even is good.
Exercise.
Yep, 100%. Hormone therapy is most effective therapy for menopause-related moderate to severe vasomotor symptoms.
Yeah, when women come in and they talk about their options for treatment, I kind of get what do they have in mind? Because if I have a patient who is just fears the thought of hormone replacement, well, let's talk about other options that we can do to treat these symptoms that you're having. And I'll start with the least invasive, but lifestyle changes. But if they want 100% all of their, and the more symptoms that they're dealing with that's life changing, why not look at hormone replacement if they're not a risk person?
I did notice that as a change. This is like a side note. It's called HT. It used to be HRT.
Yeah.
Remember, in the
replacement therapy.
Remember, and I'm like, wait a minute, that's kind of new to me therapy. That it's HT.
And before HRT, it was ET.
Really?
Estrogen therapy. Yeah.
Isn't that funny? I just find some of this stuff unique. Sorry, that's a side note. Sorry about that. Severity of symptoms based on level of bother. You just talked about that. You can look at the tables if you want to look at hormone therapy options that your book talks about, non-hormone therapy options, and of course, vaginal and intrauterine hormone therapy options as well.
Well, speaking of, please, please, please do not be one of these providers. If you're going to give them hormone therapy, please make sure if they've got a uterus that you do not give them unopposed estrogen. And what this hormone therapy, intrauterine hormone therapy option is the Mirena IUD. And that is a very acceptable way that you can give them an estrogen patch or a pill and put in a Mirena. Insurances even cover it. That's enough protection, gives you 7 years of protection right there. Of course, hopefully they're not going to be on hormone replacement that long, but even if you're using an IUD to carry them through their contraception until they go through menopause and they're there at menopause, you can easily give them hormone replacement for the rest of the life of that IUD and still protect the lining of their uterus. So,
cool.
Yeah. So that's what that's referring to.
Cool. So hormone therapy protocols and formulations, estrogen therapy prescribed exclusively for women who had a hysterectomy, right? Exclusive. Side effects and management, you can read in your table for that. Whereas the estrogen progestin therapy takes sequentially or continuously.
So if I've got somebody who, let's say I can't prescribe a low dose pill, she's perimenopause. It may be that she has 3 periods last year. She's, having hot flashes. If I put her on hormone replacement continuous, chances are she may have some bleeding if she continues to have some of that hormone function of her own. So that's the problem that you're risking when you start somebody on hormone therapy. If they've had a period pretty often within that past year. So that's why we choose low dose birth control pills to still in that perimenopause time. But most, I think it depends on the preference of the provider, but most women, once they start their periods, they don't want to have a forced period. And that's what that sequentially means.
Yes.
So most women want to take it continuously so they don't have a period. Yeah. So, I don't do that very often. However, for that first year, if it's not been more than about 6-9 months and they've had a period, I may put them on that cyclic regimen that I call a period for about 6 months before I turn them over to the continuous therapy. It just prevents bleeding and scary bleeding to them.
Right. Oh, yeah, of course. Estrogens differ in target tissue response and dose equivalency.
Yeah, you're going to start with the lowest dose and work up rather than the higher dose and work down.
Makes complete sense. Start low and go slow. Progestogens.
Okay.
That's a good word.
Hormones that possess the progestational properties. So there's something called micronized progesterone. And this is a little bit different than just your synthetic progestin. So if you have somebody that comes in and you're going to give them hormone therapy and they want as natural as they can come.
Okay.
My thoughts on that is a hormone's a hormone, but if you want a more natural based like a micronized progesterone, we can use that as an option. So they used to package that, or a brand name is called Prometrium, and that's comes in 100 milligrams and 200 milligrams. 100 milligrams has been studied that I can give them an estrogen and protect the lining of their uterus with 100 milligrams of micronized progesterone. So you don't have to use the medroxyprogesterone, the norethindrone acetate. You can use micronized progesterone, and it's now generic, and some women do get some benefit from that progesterone, not only to protect the lining of the uterus. It's the relaxing hormone, so it helps them sleep a little bit better at night. And still you got that uterine protection.
Wow.
That's what that means.
Thank you for that. So estrogen basodoxifene therapy.
There's a brand that has come out with that particular, and honestly, I've not used it, a lot of it. It's name brand. I have a hard time getting insurances to cover, but it's a different progestin component that's in a combined pill.
Okay.
Basically.
That makes sense.
Mm-hmm.
Estrogen androgen therapy. No androgen therapy is currently approved by FDA for use in women.
No, however, we have something on the market that's now generic called Estratest. And we've had that for a lot of years, and it's not my favorite, but it's basically a little bit of estrogen and a little bit of testosterone, because the thought was that when we lose our ovarian function, that we lose that little bit of testosterone production. And so we're going to give these women that replacement in estrogen and the testosterone. And it's a good thought, a good concept. But what I don't like about it is it's a dose of estrogen and a dose of testosterone, and then the half strength is half that of each one. So that's the only way you can manage that. So there's full strength and half strength. But I've noticed, and I've got a couple patients on it that has done pretty well. If they lose their libido, they do like that little bit of testosterone. But that doesn't have any progestin quality in it.
Right.
So a lot of women has had a hysterectomy with their ovaries removed that use that, but more recently insurances are avoiding paying for that, even the generic. So there's nothing else on the market like that. Yeah.
Right. And then there's some natural stuff and bioidentical stuff available.
So in women,
not approved by FDA.
Yeah, women they may be open to using hormones, but they don't want anything that's synthetic. They don't want there's a common estrogen called a conjugated estrogen called Premarin, and it's from pregnant mare's urine. But I'm going to tell you something, women that use that, it takes care of all kinds of hot flashes. It's a really good replacement therapy, but they don't want to have that in any kind, shape, or form. But when they talk about natural hormones, most of them are wanting the bioidentical, which is a biogenically very similar to what our bodies used to make. Yeah. So there's some approved hormone options that you can prescribe that are considered bioidentical without going to a compounded pharmacy, and it's still regulated by FDA. So number one is a transdermal estrogen, and that is considered bioidentical. So any of the estrogen patches, the estrogen creams or gels that are in pumps that, we can get insurances sometimes to cover these. So they're applied daily to the skin. I actually like transdermals over the oral if I'm going to prescribe that, because it bypasses the liver.
Right.
So when you give a person estrogen, their risk for blood clot formation increases, breast cancer increases, but you can bypass that liver where sometimes that blood clot begins, and by using transdermals you decrease that risk of blood clot formation. So I've actually used a lot of patches or the gels that women can put on. So that's a bioidentical way of getting that. And then the micronized progesterone is considered bioidentical. Even though you're taking that orally, it's bioidentical. So there's some options there that you can satisfy those women.
Leading into progesterone creams, several available over the counter.
Yeah. Wow. You can go to a health food store, and it's a Mexican yam that has some phytoestrogens. It's not really progesterone. No, they're not FDA approved, but a lot of women think that they're doing right by going to these
homeopathic.
Yeah. Is it going to hurt them? Probably not. Is it going to help? Probably not. But if they think it helps,
placebo it, maybe.
Go for it.
Plan of care and patient education, of course, is so important. Vasomotor symptoms begin to resolve in 2 to 6 weeks after we give hormone replacement therapy. Offer them guidance about management of these side effects. If it's discontinued, 50% of symptoms will reoccur.
Yeah. And 50% chance symptoms will. And I tell them that. It's like, okay, if you start hormone replacement, at some point, you're going to have to stop. And then you just delayed this going on. And so your risk of having these symptoms come back up are about half the time.
Yeah. Complementary alternative medicine offers several options. There's some herbal things not regulated by FDA. Those are on table 1411. You've got isoflavones. Those are coming from plants, estrogenic and anti-estrogenic properties, and acupuncture once again. And that ends our presentation. And we want to thank you guys for joining in, and we'll return soon. Bye.